Okay, good morning, everybody. I think we can start now. There is also a stream in another room. This room actually holds around 1,000 people, but perhaps others are watching it elsewhere. So really, I'd like to say good morning to you all. It's so good to see you again. It's been really 3 long years since our last Lisbon Addictions Conference. I'm Rosemary de Souza. I'm head of communication at the Drugs Agency. And on behalf of the organizing committee of this conference, I would like to extend a warm welcome to you all. This is our 4th European Conference on Addictive Behaviors and Dependencies, Lisbon Addictions 2022. Yeah. So all of us from the organizing committee really wish you an inspiring and enriching time here over the next 3 days. Just before we listen to our opening speakers, I have a few practical points to mention. So first of all, I'd like to tell you that all the sessions that take place in this room are being recorded, and they'll be made available to the general public after the conference via our websites. Second, there's a team of colleagues on hand to help you. So if you feel lost or need any assistance, you can identify them in this polo shirt, gray long sleeve polo shirts, like the one I'm wearing. So please, if you're trying to find a room or need some other assistance, please do look out for these colleagues. Many of us around. Another thing I'd like to tell you about and draw your attention to are the 2 social events we've planned for today and for tomorrow. So this evening, we have the welcome cocktail that starts at 7:30 and goes on till 9:30. It's a welcome cocktail with a finger buffet, and we really would like all of you to attend. You don't need to have registered for it. We think it's a great opportunity for you to just hang out and carry on networking. And then tomorrow, from 7:30 to 10, we have the networking buffet dinner. We've catered for everyone. Again, you're very welcome to attend this dinner as well. We'd very much like to see you there. So please don't worry. I think we sent out a request for registration some time ago for these 2 events, but really they're open to all, and we are looking forward to seeing you all there. There's one other aspect that I think that might be interesting for you to know. We have, I don't know if you've seen it already, that way, we have the Knowledge Market Lounge. So it's right at the end of the long corridor with the photo exhibition. And that's an area where you can charge your phones and computers and just, well, simply spend time networking and chatting there. And there's always coffee and tea there, so you won't go thirsty. So I think those are the remarks those are the things I needed to mention to you. So now I'd like to hand over to João Goulão and Alexis Goosdeel for the welcoming remarks. João is the General Director of SICAD. That's the General Directorate for Intervention on Addictive Behaviors and Dependencies. He is also the National Coordinator for Drug Problems, Drug Addictions, and the Harmful Use of Alcohol. Alexis Goosdeel is the director of the European Monitoring Center for Drugs and Drug Addiction, the EMCDDA. So, João and Alexis, you have the floor. We look forward to what you have to tell us. Thank you very much.
Thank you, Rosemary. It's impressive to see at this time already so many people in the room. It's very good to have you here. Dear Alexis, distinguished participants, it gives me great pleasure to extend to you all a very warm welcome and to say how pleased we are to convene this fourth European Conference on Addictive Behaviors and Dependencies, again here in Lisbon. As you know, the fourth conference had been scheduled for 2021, but the COVID-19 pandemic forced us to postpone, and we have used the time to prepare for this year's edition an ambitious program exploring challenges relating to illicit drugs, alcohol, tobacco, screen addiction, gambling, and other addictive behaviors. We have come a long way since the decision to create this European Forum as a reference for science, research, and innovation, ensuring that knowledge generated by research is taken into account by decision makers. The success and increased dimension of Lisbon Addictions from its first edition in 2015 demonstrates how this multidisciplinary conference, which promotes the sharing of research that inform policy discussions and support effective intervention, is very much appreciated. Lisbon Addictions 2022 has become the largest European conference in the area of addictions, and we are very confident that it will again showcase the richness of research and will contribute to the dissemination of more and better science that can inform and support decision makers and professionals in their everyday choices. We will have the opportunity to hear presentations from researchers, practitioners, and policy experts from different disciplines that extend the frontiers of addiction knowledge, identify new threats and challenges, and highlight new opportunities for action. Global addictions, the overarching theme of this year's conference, will be explored from a variety of angles, from international policies and interventions to innovative methods and human rights, in order to reflect the evolution and increasing complexity of addictions, the emergence of new behaviors, and the changing communities. Ladies and gentlemen, this year, more than 1,900 participants from 88 countries have registered for the conference. I would like to express my sincere thanks to all our honorable speakers. The event could not have been possible without your commitment. During the next 3 days, over 1,000 presentations will be given across 200 sessions, ranging from plenaries, big debates, structured sessions, workshops, oral presentations, short communication, and e-poster guided tour. Over 25 internationally renowned researchers and professionals will be contributing with their expertise in keynote speeches and on panels. 2 big debates will see groups of discussion, exchanging views and experiences on key questions related to global addictions. Once again, a co-producer's approach has been used to shape the conference program around thematic tracks. We worked closely with 7 co-producers to develop a rich, diverse, and innovative program by taking joint responsibility for organizing thematic tracks around a large variety of topics as global drug policy, drug markets, alcohol dependence, mental health behavioral addictions, prevention, infectious diseases, and drug-related harms. Interglam, an European project co-funded by the European Commission, awarded bursaries to support 120 conference participants who would otherwise not be able to attend, and is co-producing the track on global perspectives on addictions and drug markets, and organized an international video competition. You can access the complete conference program through our website, and we recommend downloading the conference app to help you select your favorite presentations. build your personal program, and create your professional profile for networking, as Lisbon Addictions is also networking. I wish to take this opportunity to thank the journal Addiction Society for the Study of Addiction, the European Monitoring Center for Drugs and Drug Addiction, and the International Society of Addiction Journal Editors that, together with SICAD, organized once more this event. Allow me to express especially my gratitude to the EMCDDA for its active commitment on the program and organizing committees and excellent cooperation since the first edition of Lisbon Addictions in 2015. The knowledge and scientific support of the EMCDDA were, once again, crucial. Thanks, Alexis, and to all your staff for your support and involvement. The conference has the backing of several renowned international partners: the European Commission, the United Nations Office of Drugs and Crime, the World Health Organization, the Pompidou Group from the Council of Europe, and the Inter-American Drug Abuse Control Commission. Allow me to thank also SICAD team involved, namely Manuel Cardoso and Sofia Santos, for their hard work on preparing this conference. Dear participants, looking at the impressive program, I am sure that once more Lisbon Addictions will provide a valuable opportunity for learning across the different disciplines involved in this challenging and dynamic area. Dear all, I wish you a very pleasant stay in Lisbon and the very best for a most productive and successful conference. Thank you.
Ladies and gentlemen, good morning, Lisbon. Are you happy to be here today? I cannot hear you. Please show it. Wake up. It's so good to be together again here. And actually, what was the first experience for the first edition, we were not even sure we would have enough people to cover the cost. It turned now it has become the Lisbon Addiction Week. We have already so many meetings the previous day. That's really a great experience. And I think after those COVID years, we measure how important and how good it is to be together. So once more, welcome again in Lisbon. I want first to thank and to say our partners a big thank to SICAD. I think EMCDDA and the SICAD teams and the partners, it's much more than institutional cooperation. It's love and passion affair. And that's what unites us in our work. I can tell you that when we receive some institutional visits, sometimes a new director from the European Commission, they are always impressed by the atmosphere, the spirit that they find when they speak and meet with people working in EMCDDA and also with SICAD, because it's much more than just a job. And I think passion is what unites all of us coming here in Lisbon for those 3 days. I want to address also special thanks to my people. EMCDDA team is fully dedicated to this conference. The entire week, every single meeting, we help to prepare, to organize. We organize to bring people from neighboring countries, for candidate countries and potential candidates to the EU. We are welcoming people and participants from the CADAP project from the European Commission and many others. So without the full commitment of all the staff, those you will see, those you will listen to in some of the meetings, but those you will not see and who made this possible, including from the administration, making sure we have the budget, we have the payments ready on time. That's a full commitment of the entire agency. And really, you make us all proud to belong to the EMCDDA. So thank you very much to all of you. And then I want to say the work of the agency would not be possible without the full support of its management board. And I want to thank Dr. Franz Pitsch, who's the chair of the management board of the EMCDDA, who's here with us, and also the chair of the scientific committee, Professor Catherine Komisky. Thank you very much to you too, and to all the members of both committees. I want to welcome young researchers and young professionals. This conference is particularly for you. We want to give you better and more opportunities to learn, to share, and also to learn how to share. So there are plenty of opportunities, and as João said, I think the conference without young practitioners, young researchers would not be the same. I just want to pay a tribute to all the friends and colleagues we have lost in the last 3 years. There are many people who are dear to us, to our hearts, very strong and dedicated researchers, professionals, and they passed away for one or another reason during those 3 years. And I think they contributed to make this conference in the previous editions what it is today. They still and will forever belong to our family, and I want to pay tribute to them. Global additions. When we choose the title and the topic for this conference, it was even before the 2019 edition took place. Since then, global is even more the key word than ever. The world has changed a lot since 2019. COVID had an impact in disrupting and then boosting the change of the market. It was disrupting the services, and unfortunately, in the European Union, except I think in Sweden, all countries decided that services to people using drugs were not essential. And this is to avoid this to be repeated that we launched a common call together with the director of ECDC and the director of Europol in June 2020. But it has been also an opportunity for more creativity and innovation from the side of researchers, for professionals, but also for decision makers. There are things, new responses, that sometimes countries, cities were struggling to create and put in place that suddenly became more possible, like a new hostel for homeless people using drugs in Barcelona or in Athena. And then there is the war in Ukraine. And I want here to reiterate the full support from the EMCDDA and from the colleagues of SICAD. And I'm happy to welcome either here in presence or online in the different meetings we had this week, colleagues from Ukraine. And then overall, we see that drug policies that are being decided somewhere else on the globe have an impact on the reality here where we live and when we work. This is why global policies are even more important, and this is why they deserve an important place in the agenda for today. So the conference, it's an answer, it's our response, our shared response to the need to move beyond operating in silos. And this is why we have cross-disciplines work, cross-professions, and when I say professions and practice, this means also nothing about people using drugs without people using drugs. It's crossing the fields of different kind of addictions or addictive behaviors, and it is crossing the continents. What we try to achieve and put in practice with the way we organize and we live the conference with you those 3 days, it's to more than ever work at the service of clients and of the community through participation and also co-production. Co-production for the design of the program, for some of the sessions, the partners for the organization of the conference, but also in our daily practice or research. So the conclusion is, if you remember, for those who were there in the previous editions, I think you are the real MAGA, making addiction great again. Yes, we do, we are. Thanks to your participation. So we're the real mega, and we need to shout it loud and show over those 3 days, and when we are back home. And it is thanks to your participation, your enthusiasm, and your suggestions. So to finish, I want to conclude with a quote from Nikos Kazantzakis, which says, "Since we cannot change reality, let us change the eyes which see the reality." During those 3 days, you will have more than 1,000 opportunities to see reality differently. I wish you a fantastic and exciting conference. Thank you very much. I think we are supposed to leave, but who is coming?
Well.
So good morning, everybody. In the interest of time, I think we're going to go straight on. My name's Sarah Welch. I'm an addiction psychiatrist and a trustee for the Society for the Study of Addiction. It feels great to be back in Lisbon and seeing so many people. Now, Lisbon Addictions was last here in 2019, and one of the thematic tracks in the program focused on opioid-related deaths, including the increasing trends relating to prescription opioids. A few things were clear to us then, and they were, I think, that addiction specialists need to understand more about pain and pain management, that clinicians in both the addiction and pain specialties are really looking for guidance, and that we all need to learn from both the tragic experiences and the positive responses relating to the opioid crisis in North America. So here we are today with 3 expert speakers who are addressing all of these 3 areas. I'm going to introduce each speaker before their own talk, but in the interests of time and the size of the room, I'm not going to be taking questions between presentations, and probably not after as well. Because of the size of the venue, it's quite tricky here. But we should have some time for discussion between the 3 experts, and we'll see how it goes. A slight change in order. Christopher Jones is going to speak second now, so we've just switched those over just in case our technical support needs to know that. So I'm delighted then to introduce our first speaker, who will make her way up here while I'm introducing her. And our first speaker in the whole conference is Dr. Cathy Stannard. So Cathy was a clinical consultant in pain medicine for 23 years, and she now has an advisory role within the UK National Health Service in South West England. She writes and lectures widely on aspects of pain management evidence and opioid therapy in particular, and the implications for public health. Cathy contributes to the work of several national and international agencies, including the former Public Health England, the UK Medicines and Healthcare Products Regulatory Agency, the UK Advisory Council for the Misuse of Drugs, NHS England, the European Medicines Agency, and the Cochrane Collaboration. She was a member of the International Association for the Study of Pain, International Task Force on Opioids, and the World Health Organization Guideline on Cancer Pain Management. She was clinical lead for the UK NICE Guideline on chronic pain and topic advisor for the NICE Guideline on safe prescribing and withdrawal management of medicines associated with dependence. She's provided in-reach pain services to 5 prisons in southwest England and frequently contributes to conversations about pain, opioids, and painkiller addiction in both written and broadcast media. As a UK addiction psychiatrist and fellow Southwestie, I can also confirm that Cathy's not only an international expert, but also a supportive colleague for struggling clinicians in her local area. So over to you, Cathy.
And I'd first like to thank the organisers for the huge privilege of being able to speak at this very important meeting, and rather daunting to be the first speaker. But so I'm getting the IT wrong already, so let me try something else. Yes, so this is quite a gentle start. I don't want anybody to take any notes. What I'm hoping is that nothing I say will be new to anybody in the audience. I'm going to tell a few home truths about pain and pain management, because obviously that has been one of the focuses in the UK relating to the use of opioids, how we use these medicines for pain. And as I say, I don't think anything here will be new, because the big secret about pain is that there isn't a big secret, really. But I'd just like to get your creative juices flowing, and would hope that I'd bring most people in this audience along with me in perhaps reconceptualizing how we think about persistent pain. I'm sorry about the... So go back one. So I put this slide up. This is from Malcolm Forbes, great free marketeer, he of Forbes magazine, who makes the important comment that it's much easier to suggest solutions when you don't know what the problem is. And I think regarding opioid prescribing in the UK, there's been a kind of naive assumption that if you just tell everybody to stop prescribing opioids, that's all that needs to happen. And you need to keep repeating the message till people do what you say. But I can say from the heart that certainly in my current role, which was around reducing inappropriate use of medicines, there's much more to it than that. So I'm going to talk a little bit about pain and about the UK national context, which is changing the conversation about pain, and a little bit about medicines for pain and prescribing dependence-forming medicines safely, and then a few takeaways at the end. So persistent pain is common, and in the UK, between a third and a half of the adult population have chronic pain. Now that should tell you that perhaps it's part of life. If half of people have something, it's probably not a disease. It's probably a part of the human condition. 14% have disabling symptoms that impact on work, relationships, and everyday life. And the reality is that most people will not see a pain specialist. And as a pain specialist, I think that's appropriate. I think people need to be supported with their pain in their local communities with the people around them. And we know that there are inequalities in relation to pain, and that it is more common in females than males. It is more common in people from certain ethnic backgrounds, and it is more common as people age. So short-term pain, acute pain, is fairly straightforward to understand. If you have a big injury, it hurts more than if you have a little injury. And pain is an everyday human experience. I don't know how many people there are in this audience, but probably several hundred will have had some fleeting experience of pain today. Persistent pain is not the same as short-term pain that just lasts longer. It has strong links to mental health and may be not associated at all with any obvious injury process. And we call that primary pain. There has been some confusion about the terms primary and secondary pain. They are what they say on the tin. Secondary pain is pain that is secondary to something, and that may be severe arthritis, it may be a burn, it may be diabetes, it may be an injury. Primary pain is pain that comes on with no apparent injury process, but where distress and disability are very prominent, and if there is any injury process, the response to that injury process is out of proportion. So somebody with maybe very mild age-related disc disease at one level of the spine who is totally bedbound and unable to function, that would be primary pain, because the disability and distress is out of proportion to the known burden of disease. And I think what's really, really important to understand is that whatever the cause of the pain, if it is grief, it is childhood trauma, if it is being run over by a bus, it hurts just as much. So I think there's a tendency to think that pain that's not directly associated with injury hurts less. It doesn't. And a good example is bereavement or grief. People who have experienced profound bereavement will often describe that their whole body hurts in a very genuine way. So whatever the cause of pain, we have to take it seriously. The reality is that medicines And medical interventions, on the whole, have no utility in the treatment of long-term pain. And that is a bitter pill to swallow for many of us who have worked in pain medicine for all our lives. But medicines often don't work, and other treatments often don't work. And of course, any treatment can be associated with harm. And we all have the message, first do no harm, that will go back to ancient times. But the only way not to do harm is to do nothing. And of course, doing nothing is not very helpful to support people with the burden of living with pain. And certainly, we spend a lot of time talking to our clinicians about the fact that opioids and other dependence-forming medicines don't work for persistent pain, and that the harms outweigh the benefits. And that might be enough of a message, but clinicians very realistically want to do something else instead. It's no use just telling them not to do everything they've done for their lives. They want something else to do instead. And what is very clear is that patients and clinicians want better conversations around pain. Interestingly, I think clinicians imagine that when a patient walks into their office with a complaint of pain, what they want is a strong medicine. But actually, qualitative research tells us something different. What patients want is they want to be believed and taken seriously, and they want empathy from their provider, and they want to be empowered to take part in their own support strategy and be partners in their own care. Patients do not really mind if you don't know the intricacies of strange receptors in the dorsal horn of the spinal cord. They want you to understand what their life is like living with pain. So they want you to understand how pain impacts everything they do and think and feel, and what that means for how they live their lives. They don't want science, and they want to be understood as a person. And I think there are some important national initiatives. I'm going to talk about medicines separately in a moment, but there's a kind of groundswell of change in thinking about how we think about a lot of long-term conditions now in the UK, but this applies to pain in particular. So in 2019, they launched the NHS long-term plan. I'm sure many of you understand that the NHS is on its knees. Waiting lists are the longest ever. Clinicians, particularly general practices, are leaving in their droves. And as we say every winter, we think the NHS is going to fall apart this winter. It may well. And certainly there are big resource issues. But the themes of the long-term plan to make healthcare, free healthcare sustainable are around place-based care. So this is not centrally dictated practice. It's around communities deciding what they need and what's important to them. It's about personalization. This is a big agenda. It's about shared decision-making and actually working with what's important to that patient in front of you. It's about integration with social care and other care providers, so voluntary sector providers, mental health and physical health, charity partners. There is now funding for, this is called the Additional Role Reimbursement Scheme, and probably the most important group of people in this are social prescribers who are very well trained. They are trained in motivational interviewing, health coaching, trauma-focused practice, and in our county also in training in attachment disorders. And they can spend time with patients with a number of chronic diseases, doing a needs assessment and providing the appropriate sort of social support. And thinking about value of intervention, stewardship of our resources is very important. There's more recently been a powerful document on the bottom right here about the future of primary care, again with more focus on a psychosocial model of care and a holistic approach to supporting health, and a realignment of the health and care system to a population-based approach. So identifying people in trouble and preventing them getting into worse trouble. And there are two important initiatives which are going to have quite a big impact, I think, on how we treat pain and particularly how we prescribe for pain. One is a commissioning framework for optimizing prescribing of medicines which may cause dependence and withdrawal. And this is going to be of key. I've got 5 minutes left. Right, okay, I've hardly started. So Is that 5 minutes since we started? We didn't start till about 10 past, so where am I up to? So, right, okay. This will be addiction services working together with other providers to look at how we support people who've become dependent on medicines, and a guide to ask people to start thinking differently about pain. So a little bit about medicines for pain. Just to say that opioid prescribing in the UK peaked in about 2016 and has been falling a little since then, but at the cost of increased prescribing of gabapentinoids. We think this isn't people being taken off opioids and put on gabapentinoids, but rather people being started on gabapentinoids ab initio. And we know for all of these dependence-forming medicines, they are more likely to be prescribed in areas of deprivation. But actually, we know the next two slides, opioids, for example, are not doing what we hope they're doing for pain. And if you look at, this is an Australian study looking at a cohort of people on long-term pain, and you can see that these outcomes are not what we would want for our patients. And this is a study from UK Biobank, again, that I was involved in with Gary McFarlane. And again, most people using opioids, 87 people using opioids, still have pain. So they're not doing what we want them to do. And they're more commonly prescribed in deprived areas. And people still have the burdens of living with pain despite taking opioids. So a little bit about the National Institute for Health and Care Excellence. Suffice it to say, it is a great privilege to work with NICE. And it makes decisions at a national level. So the evidence is very, very, very robust. And the bar is quite high and is criticised for being quite high. And the reason we have NICE is that we've got to give our taxpayers the best value for money. The chronic pain guideline came out in April last year. It deals with assessment of all types of pain, so pain associated with injury or disease and primary pain, and then looks at the treatment of chronic primary pain. And just to remind everybody that most of people, so 85% of people with back pain, for example, probably have primary pain. 85% of people don't have an obvious, profound, organic process going on. And this is what we find. The most important thing about treating pain is an empathic, person-centered relationship. That's what matters more than any medical treatment. The only recommendation that is applied to the whole population out of this guideline is exercise. And that is exercise delivered not by physiotherapists, but by qualified exercise instructors. And this improves physical health, mental health, psychological functioning, social functioning, and quality of life in the medium and long term, and is very cost effective. A 10-session exercise intervention which changes attitudes to exercise for the rest of that person's life costs about £80, which is very cheap. Psychological interventions have a less strong recommendation, CBT and ACD, but there is a do not recommendation for all classes of medicines other than antidepressants. And this has been quite a shock to prescribers, that NICE argues against medicines for the treatment of pain. And there's a recommendation for acupuncture. Sarah, how am I doing for time? So I'm totally lost now.
It's okay, Cathy. Haven't taken another 5 minutes. We started a little bit late and we have got plenty of time.
Right, okay. So the medicines recommendations are unambiguous. Prescribers are told not to initiate any of these drugs that we've known and loved for many years. The only medicines which are recommended for the treatment of pain are antidepressants, and they will help with quality of life, sleep, and psychological distress, even in the absence of a diagnosis of depression. So antidepressants are the only drug class that have survived the cull of medical pain treatments. But just to say, contrary to what many of the papers said in the UK, this does not mean, and this is part of what the problem was in the States, summarily taking off medicines they're already on. If people are in safe doses and they're doing quite well, they can be kept on these medicines, but they must be kept under review. The recommendations are about initiating these medicines in the first place. I had an evidence matrix key, which I won't go through. I'll go into the kind of just looking with your eyes screwed up from the back of the hall. Essentially, this is a guideline that wrote itself, Green means there's strong evidence for effectiveness and economic evidence. Blue means there is evidence for something not working. White is no evidence, and red is evidence for harm. And you can see that this has all the interventions listed down the left side, and you can see it moves from green being predominantly the colour, more uncertainty, white creeping in, until we get down to the bottom where red is medicines. And all medicines other than antidepressants cause more harm than good for pain patients. And there are a number of NICE guidelines for different disease processes, and they nearly all counsel against medicines for pain. And Professor Jones is here. Suffice it to say, the CDC guidance has been updated recently in the past couple of weeks in the United States. The 2016 guidance had the problems that we talked about, so people summarily being taken off medicines, it being applied to populations that it didn't, it wasn't written for, people being abandoned by their clinicians. And these points are really, really clarified in the new guidance for opioid prescribing. And the themes, all I'm going to say at this stage, the themes of the new CDC guidance are very concordant with the findings of the NICE guidance. All I'm going to say here is that earlier this year, there was another NICE guideline, medicines associated with dependence or withdrawal, safe prescribing and withdrawal management. Again, so this is not saying that for all patients everywhere with cancer or other sorts of conditions, these medicines should not be used, but when they are going to be used, they should be used in a safe way. And we do distinguish in this guideline between dependence, which is a expected effect of many medicine classes, and addiction, where we have different behavioral attributes that complicate treatment. I'm going to, the next two slides I'm going to go through, they make a point, but this guidance covers supporting people to take medicines, making decisions about taking and prescribing medicines, how to start, review, and stop a medicine. And it contains very, very important guidance about what to do when the prescriber and the patient disagree about what medicines they should have. Because there is a balance between shared decision-making, personalization, empowerment, and not letting a patient say, I want 10 grams of morphine a day. And there's a balance to be struck there, and there's ethical guidance in here about what to do. And so I've just got some final messages that I think in the UK particularly there is definitely an emerging recognition of the complexity of chronic pain and understanding it not just as a long-term disease but as a psychosocial problem. Many patients with early childhood trauma, conditions like fibromyalgia, about 90% of people will have had childhood trauma. And the great importance of assessing through that lens, understanding that people will have awful lives and that's why they have persistent pain. Prescribing medicines are going to make a bad life worse, and so on the whole should be avoided. And building better relationships becomes before, during, and after deprescribing. So our clinicians say to us, will you stop telling us to reduce opioids, to reduce gabapentinoids? Let us build relationships with our patients, let us build trust, and then they will believe us when we tell them that they should come off their medicines. And changing prescribing practice is about much more than medicines. So my role now is about building many other support services, large in the community, psychosocial support services for people living with pain. But my role is not about reducing pain intensity. It's about all that other stuff around the edge. And I think that's how we're now thinking about pain in the UK. That's it.
Thank you so much, for Cathy, for opening this session with such an inspiring talk. I'm going to introduce our next speaker, who's on his way up, and that's Dr. Christopher Jones. So Christopher currently serves as the acting director of the National Center for Injury Prevention at the US Centers for Disease Control and Prevention. In this role, he oversees all aspects of the Injury Center's work and provides scientific leadership to drive the centre's strategic direction and to advance their priorities of preventing drug overdose, suicide, and adverse childhood experiences. Dr. Jones has worked in multiple leadership roles in public health and behavioral health, including at the Substance Abuse and Mental Health Services Administration, the US Food and Drug Administration, the US Department of Health and Human Services. He maintains an active research portfolio, and he's authored more than 100 publications on the topics of substance use, drug overdose, adverse child experiences, mental health, and other topics relating to the impact of violence and injury. So very much welcome to Christopher Jones, and I'll pass over now.
Thanks very much, and thanks to the organizers for having me be part of the panel, and thanks, Cathy, for setting the stage. I want to give sort of a brief overview of sort of where we are in the U.S. with the overdose crisis, and then get back to pain and the updated CDC guidelines at the end. And I like to put this slide up to just give some context of sort of where we've been and where we are in the U.S. with respect to drug overdose. And you can see here that overdose deaths in the U.S. have largely been increasing since the early 1980s. As we started to see opioid prescribing practices change in the mid-1990s, a large increase in the volume of opioids, prescription opioids in the community, prescribed at higher doses, longer periods of time, often prescribed in combination with benzodiazepines. We saw prescription opioids really be the primary drug that was involved in overdose deaths. But over time, that has shifted. We first saw heroin sort of reemerge in 2010, 2011, and really since 2013 in the US, overdose deaths have largely been due to illicitly made fentanyl analogs, other synthetic opioids that are in the illicit drug supply. And 2021, it's certainly the worst year that we have seen so far. You can see about 107,000 overdose deaths in the US in 2021. The pandemic definitely exacerbated. We had about a 30% increase in overdose deaths between 2019 and 2020, and a further 13% increase in 2021. And that's sort of the historical perspective. And this is just looking sort of year over year by month over the last several years, just to give a picture of the impact of COVID-19 on drug overdose deaths in the US. And you can see that 2018, there was a small decline, about a 4% decline in overdose deaths in the US in 2018. And that was really in the last 6 months of 2018. By the middle of 2019, overdose deaths had started to increase again. So even prior to COVID-19, overdose deaths were increasing. But you can see that in those first few months of COVID in the US, March, April, May, there was a substantial increase. That's the red line here, with a peak in May of 2020 that did settle down a bit for the rest of 2020, but it sort of shifted the line up. And you can see that each month after May 2020, there were significantly more overdose deaths than in the prior 2 years. And then in 2021, that continued. We really see every month in 2021, except for May, the number of overdose deaths were higher than in 2020. And I've put the first 3 months of 2022, which certainly look worse than 2020, 2019, and 2018, but pretty comparable for 2021. Some of our early provisional estimates for about the first half of 2022 suggest maybe a little bit of plateauing in overdose deaths, but given the illicit drug market and the unpredictability in the illicit drug supply, I think we have to really wait to see if that trend would continue or if it's just a temporary sort of flattening that will then ultimately go back up. But we are certainly in unprecedented territory, which is interesting because when I gave this a similar talk in 2017, I said we're in unprecedented territory in the US, and it certainly has escalated substantially since then. But what we do see is that opioids, largely illicit opioids like fentanyl and fentanyl analogs, as well as stimulants, are the primary drugs that are involved in overdose deaths. We have a data system at CDC that collects detailed information on toxicology from overdose deaths across the US. And what we find is that about 95% of overdose deaths in the US involve opioids and or stimulants. So less than 5% involve other drugs that are where opioids or stimulants are not involved. Largely the stimulants are methamphetamine, and to some extent cocaine as well. So again, very much driven by illicit drugs, not prescription drugs, which is different than it was a decade ago. So just looking a little bit more at opioid-involved overdose deaths, again, about 88% of opioid-involved overdose deaths in the US involve synthetic opioids like fentanyl, illicit fentanyl. About a quarter involve psychostimulants with abuse potential. That's largely methamphetamine, but based on the coding system in the US, it sort of gets lumped into a broader category, but pretty much that is capturing methamphetamine-related involvement. And then cocaine, and far less involvement for natural or semi-synthetic opioids, which typically is the prescription opioids, hydrocodone, oxycodone, oxymorphone, codeine, and then benzodiazepines, heroin, and methadone is infrequently involved in overdose deaths, less than 5%. So again, we continue to see that the synthetic opioids are the primary driver here. And when we look at demographics over the last 4 years, we see that everybody has been impacted with increases in opioid-involved overdose deaths. Certainly males more than females, but females have also experienced increases. And when we look across age groups, everyone has seen some level of increase, but we tend to see in the 15 to 45-year-old age group is where the largest increases are happening or the highest rates are happening. But interestingly, from a race ethnicity perspective in the US, for many years, overdose deaths were largely among white populations in the US. But in recent years, we have seen both tribal populations, American Indian, Alaska Natives, as well as African American populations actually overtaking rates for drug overdose death in the US. And I think it really gets to issues of equity and inequities in risk for substance use and overdose, and lack of access to evidence-based treatment or harm reduction services among many communities of color. And then when we look at geographically, like we see in other demographic groups, everybody has experienced an increase in overdose deaths in recent years. I want to switch now to talk just a little bit about stimulants, because that is sort of the new overlay of overdose deaths in the US, but it is very much connected to the opioid problem in the US. So this first slide just looks at about a decade-long trend of psychostimulant overdose deaths. Again, pretty much methamphetamine-related overdose deaths. And what we see here is that, in particular in the last couple of years, deaths where opioids are also involved are driving that increase in psychostimulant-involved overdose deaths. But we do see a significant increase in psychostimulant-involved deaths that don't involve opioids. But you can see really moving into the pandemic period, there is a divergence of the rate of increase where very much this is opioids plus psychostimulants, largely opioids plus methamphetamine. And one of the things that I've been interested in my research is trying to unpack this a little bit. So when we look at mortality data, we can see what drugs were involved, but we don't know, is this driven because the illicit drug supply is mixed and people are getting opioids unknowingly? They think they're using methamphetamine, but they're actually getting exposed to fentanyl or fentanyl analogs? Or is this fundamentally a shift in the substances and patterns of substance use in the US? So we've looked through a variety of data sets to understand how are methamphetamine use patterns changing in the US. And what we see from our National Survey on Drug Use and Health, which is an annual sort of survey of prevalence patterns of substance use, we see that really however we define it, methamphetamine use has been increasing in the last several years, and it's been increasing across a broad range of demographic groups. It's not really isolated to any particular group. We see increases among males and females, most race ethnicity groups, most age groups. But one of the other things that we found in this analysis is that more risky patterns of methamphetamine use have been increasing more so than just overall rates. So whether that's people with a use disorder, people who are injecting methamphetamine, more frequent use of methamphetamine has been increasing, which helps explain some of what we're seeing in the mortality data. We also looked in our treatment data system. So people who are coming into treatment, what drugs are they using? And we find similar patterns where methamphetamine use has been increasing over time, again, across a broad range of demographic groups, not isolated to any particular group. And what we found also in the treatment data is that increasingly, people who are reporting methamphetamine use are also reporting opioid use. Again, consistent with what we see in the mortality data, what we've seen in small research studies in different areas of the US, which was suggesting a signal of increasing co-use of opioids and methamphetamine. Most recently, we looked at the treatment data to understand, are we also seeing shifting patterns of how methamphetamine is being used? And what we found at a national level is that largely the increases for methamphetamine are explained by people who are injecting methamphetamine and a shift away from smoking. Again, that's consistent with some smaller studies that were emerging in the US and very much tied into what we were seeing with the co-use of opioids and stimulants, where people were already using opioids, many of them were injecting, and they're adding methamphetamine onto that. So they've already crossed the threshold into injection, and they're adding methamphetamine. But again, it's not always the case. Some people are injecting opioids and smoking methamphetamine. But we are certainly seeing that overall signal. And again, we found that increases in injection were not limited to any particular group. Really across the demographic groups that we looked at, we saw increases. And we saw increases whether or not somebody was also using opioids or they were using other substances as well, as you can see on the slide here. So now I want to shift to cocaine, because I think cocaine is a different story. There's a clear signal for methamphetamine use with and without opioids and harms from methamphetamine with and without opioids. But when we look at cocaine involved overdose deaths, we see that almost all of the increase over the last decade has been when opioids were also involved with cocaine. And you can see just a small increase from 2020 to 2021, but overall, a very different pattern than what we see for psychostimulants like methamphetamine. And that's consistent with the use data. We looked at our National Survey on Drug Use and Health and found that while overall cocaine use was up in the US, it was largely an increase among people who are very infrequently using cocaine. And when we looked at people who had a past year use disorder for cocaine, people who were injecting cocaine, those indicators were all declining over time. So we do see an influx of cocaine availability in the US. There's historic production in coca-producing countries that is certainly making its way into the drug market, but it's not contributing to harms in the same way that we're seeing with methamphetamine. But as we think about where we are in the overdose crisis, I really want to focus on polysubstance use as well as mental health. And I think Cathy mentioned this in the pain context, that these issues are not isolated, that mental health and substance use and even pain are all very much interrelated. And as we think about what are the policies that need to be brought to bear to address this problem, we have to look at it not as a single drug problem, but really as what's driving this underneath. And really, any way that we have cut the data, we see that people who are using opioids are also using other substances. And if you're in clinical practice, this is what you see every day. People are often using what's available, or they're adding different substances to try to get a synergistic effect, or they're using opioids to come down and stimulants to get up or to show up for life, to go to work every day. And we see that that is consistent among people with opioid use disorder. One of the things that I thought was particularly important from this analysis is just the high rates of co-occurring mental illness among people with opioid use disorder. About more than two-thirds of people had any mental illness, and about a third had serious mental illness in the past year. And certainly in the US, our system historically has not been set up to handle co-occurring disorders. If you go through the mental health door, you get mental health treatment. If you go through the substance use door, you get substance use treatment, but you may not get your mental health addressed and vice versa. And we know that if we're not addressing both of these challenges and the other physical challenges that people may be experiencing, that people are not going to do as well as they could. Even if they're getting evidence-based medications for opioid use disorder, they're going to have suboptimal treatment outcomes. The same story when we look at methamphetamine. We see that people who are using methamphetamine are also using a variety of other substances and have high burden of co-occurring mental illness. And all of this is connected to what's going on in the illicit drug supply in the US. These are data from a variety of law enforcement agencies in the US. that document a large influx of fentanyl analogs coming into the US, as well as increases in methamphetamine. And really, the proliferation of counterfeit pills are enabling areas across the US to be flooded with highly potent, unpredictable substances. People think they're getting 2 milligram Xanax, and they're actually getting pressed fentanyl tablets. 30 milligram oxycodone is a commonly misused prescription opioid, something that people value, but oftentimes that's not what they're getting. They're getting some furanylfentanyl, acetylfentanyl, carfentanyl. You have no idea what you may be getting. And increasingly in recent years, we've also seen pressed methamphetamine to look like stimulants that are treated to treat ADHD. So things like Adderall or dexedrine tablets are pressed methamphetamine because there is a market for pills in the US. We still see far larger numbers of people who report misusing prescription opioids or prescription stimulants or prescription benzodiazepines. So there is demand, and drug cartels are very smart in trying to meet demand. And so it's very cheap to make fentanyl, to press fentanyl into tablets or methamphetamine as well. So the changing patterns of substance use are very much connected to the evolving illicit drug supply in the US. So what are we doing about it? We released an overdose prevention strategy from the US Department of Health and Human Services, which is the overarching agency where the health components sit within the federal government, that focuses on 4 areas: primary prevention, evidence-based treatment, recovery support, and harm reduction. Recognizing that doing just one of those areas is not going to cut it, that we have to do those in a holistic way. And in the primary prevention space, that's true primary prevention of substance use, looking at social emotional learning, strength-based programs to reduce initiation of youth substance use, but it is also about addressing pain and pain care and developing new treatments for pain. As Cathy mentioned, there's not a lot of evidence to support any of the treatments, particular medication treatments. So how do we harness the research enterprise of the US to invest in new modalities to improve the lives of patients who are living with pain? So that falls under the primary prevention bucket. And at CDC, we sort of take those 4 large pillars and put our work into 5 particular areas. In the interest of time, I won't go through that, but to say that it is trying to really bring multiple components of communities together, recognizing that there's no single agency that is going to have all of the solutions that need to be brought to bear to address the overdose crisis. So we're providing funding, technical assistance to communities to engage with health departments, mental health agencies, substance use agencies, faith-based partnerships, other community organizations, harm reduction programs, syringe services programs, to say we all have a role to play. How can we work better together to address the holistic needs of people who are using drugs, people who are struggling with pain, and how do we eliminate or reduce substance use initiation in the first place? How do we make sure that people are connected to care? And then how do we help support recovery and advance harm reduction? So getting back to the topic of pain, similar to estimates in the UK, about 1 in 5 Americans have chronic pain in the US. And it's really one of the most common reasons why somebody comes to a healthcare provider. They have some sort of acute pain or chronic pain. And it is truly a public health imperative to improve the lives of patients who are living with pain. As was mentioned, CDC released a guideline in 2016 that was intended for patients who were starting or being considered for opioid treatment for chronic pain in the outpatient-based setting. The challenge was that the way the guideline was written, it was very easy to take pieces of it and put it in law, put it in regulation, so that it became a one-size-fits-all approach. Patients who were being treated for cancer, palliative care, end-of-life care, sickle cell disease, patients who were receiving buprenorphine for opioid use disorder treatment, all of a sudden got lumped in to this group. And so patients who even had been on opioids for many, many years and who were doing well, also all of a sudden were told, I can't prescribe to you anymore, or I have to get you to a lower dose. That was never the intention, but that is how it played out in many cases. And so we certainly saw, both in stories from patients living with pain as well as in the research literature, that there were unintended harms as a result of the guideline. Individuals who sought out opioids in the illicit market because they had been abandoned from care. Patients who had suicidal ideation, suicidal attempts, mental health crises, any number of challenges as a result of misapplication of the 2016 guideline. So we knew that the science had advanced over the last 5 years, that there was a better understanding of how to approach pain, as you saw from the UK guidelines, really moving away from an over-reliance on medications to non-pharmacological treatments and thinking about the holistic needs of patients. But we also recognize that how we structured the guideline, the words that we used, where we put information, the caveats that we put in needed to be updated in order to safeguard really the patient-provider relationship so that patients could gain access to evidence-based pain care. So on November 3rd, we released an updated guideline that replaces the 2016 guideline. I was a co-author on this guideline. So it does capture and distill the latest scientific evidence based on 5 systematic reviews that were conducted. That's really the scientific undergirding of the guideline. It also expands recommendations not to just chronic pain, but also acute pain and subacute pain. And part of that is the recognition that those initial decisions between a patient and provider when somebody presents with an acute injury can set the trajectory for how a patient may move to chronic pain or initiate opioid therapy as an acute response for pain that ultimately becomes long-term opioid therapy simply because they were prescribed it and they just kept prescribing it. So we really wanted to provide guidance to clinicians to support that conversation with patients about those early decisions around acute pain, reassessment before people move into chronic pain. We're also very explicit that this guideline does not focus on patients who are receiving care for sickle cell disease, cancer, palliative care, end-of-life care. And we structured the guideline to really embrace the idea that pain care needs to be individualized. It has to be patient-centered and built on a foundation of shared decision-making between patients and providers. And that language is throughout the guideline. We also included a focus on equity, recognizing that there are huge disparities in what type of pain care you get, depending on who you are, what you look like, what means you have, and where you live. And if we're really going to advance pain care in the US, in the interest of improving pain, function, quality of life, but also reducing the inappropriate use of opioids and reducing harms from prescription opioids, we have to do it in an equitable way. And patients should have access to the full complement of pain treatments. So as I mentioned, it includes acute pain, subacute pain, health equity. We also structured the recommendations based on lessons learned from 2016, where we are very clear about what recommendations apply to patients who are initiating or being considered for initiation of opioids, and what recommendations apply to patients who have already been on opioids. And as Cathy mentioned, similar warnings that if a patient is on opioids, even if they're on high doses of opioids, but they're doing well, they understand the risks, they're taking steps to mitigate risks, such as having naloxone around, or talking with their doctor before other CNS depressant drugs are prescribed, there's no requirement to adjust their treatment. We should continue to monitor, engage with them, make sure that their goals from a patient's perspective are being met. And I think that's an important distinction, that this guideline in no way is a one-size-fits-all approach. It's not a policy, it's not a regulation, it's not a law. It is really a clinical tool to inform that decision between patients and providers. We also include a recommendation specific around tapering, recognizing that tapering carries risks, very real risk. And part of the benefit-risk equation needs to be, do the benefits of keeping the patient on opioids outweigh the risk of taking them off? And that's a clear departure from what was in the 2016 guideline, where there wasn't a lot of direction around how to taper, and oftentimes patients were abruptly discontinued or rapidly tapered to lower doses. And we talk about practical tips for clinicians about how to approach a taper in discussion with the patient, how to go slow if you do decide to taper opioids. And again, I think that is an important update to the guideline for 2022 over 2016, because that's where patients and providers really got into trouble, and where we started to see harms when patients were rapidly tapered off of opioids or discontinued. So just to wrap it up, we continue to see a very dynamic and evolving overdose crisis in the US, one that has shifted from prescription opioids, predominantly driving overdose deaths, to heroin, to synthetic opioids like illicit fentanyl and fentanyl analogs. But really, on the whole, this is a polysubstance use issue. Most overdose deaths involve multiple drugs. Increasingly, we see that substance use patterns are changing, in particular increased opioid and stimulant co-use, including injection, which has its own host of issues for overdose as well as infectious disease consequences. And this is very much tied into the illicit drug supply and changing drug supply in the US. And the last thing I'll say is as we think about policy, we need to focus on treatment, harm reduction, improving access and retention in care, but at the same time, we have to think about balanced approaches to addressing pain, and that patients with pain deserve empathetic, evidence-based care, and that it should be a part of the continuum and the conversation as we're thinking about substance use and overdose prevention as well. So thank you very much, and happy to take questions later.
Thank you so much to Chris for that, firstly for sharing with us those very rich data sets and also so elegantly presenting the challenges of both issuing guidelines and working out how people respond to them and use them and then responding again. That was really, really helpful. Thank you, Chris. Our final speaker is Professor Winfried Häuser. He is a senior physician and specialist in general internal medicine, psychosomatic medicine and pain medicine at the Academic Hospital in Saarbrücken in Germany. He's a member of the Ambulatory Pain Medicine and Mental Health Care Center in Saarbrücken, and he offers specialist consultant hours for patients with fibromyalgia and chronic abdominal pain. He's an adjunct professor for psychosomatic medicine at the Technical University of Munich, and his areas of research are psychosomatic aspects of bowel diseases, functional somatic syndromes, evidence-based medicine, and healthcare research. He's co-editor of the Cochrane Pain, Palliative and Supportive Care Group and head of the steering group of the German Guidelines on Fibromyalgia and Opioids in Chronic Non-Cancer Pain, and member of the steering group for the European Alliance of Associations for Rheumatology Recommendations on the Management of Fibromyalgia. He's head of the European Pain Federation Task Force for a position paper on cannabis-related medicines for chronic pain and on opioids for chronic non-cancer pain. He's published more than 300 papers on chronic pain conditions, including systematic reviews on pharmacological, psychological, physical, and complementary and alternative therapies for chronic pain conditions. So if we can welcome Winfried, thank you.
So I thank the organizers for inviting me and giving me the chance to comment from a European perspective on the North American opioid crisis and to present the recommendations of the European Federation on appropriate use of opioids for chronic non-cancer pain. So I have no financial conflicts of interest to declare. As you have heard, I'm a clinician and have to confess I prescribe everyday opioids for patients with cancer pain and palliative care. And in my outpatient department, I sometimes prescribe opioids for some patients with chronic secondary pain syndromes. So now I've come to the uncomfortable position as the one who has an emotional conflict of interest towards aerobic exercise and psychological therapies to defend opioids for some selected patients against politicians and guideline makers. Though this is my topics I want to talk about with you. If there an opioid crisis in Europe, and again, this opioid crisis is a North American term, and it means that there has been a parallel increase of prescriptions of opioids for chronic pain, an increase of the abuse of these prescribed opioids, an increase of death and emergency visits due to overdosage. I want to comment on the US opioid crisis from a German point of view, and I want to present you the main recommendations of the EFIC to ensure adequate balance between pain relief and reducing the risk of addiction. Though is there an opioid crisis in Europe too, if we believe the OECD? Yes, it would be, because there has been an increase in opiate prescriptions, at least until 2016 in the Western European countries, and as well an increase of death. But honestly, nobody can tell you if these increases in opioids have been for acute pain, for end-of-life care, or for chronic non-cancer pain. And we do not know any reliable data in Europe if these increases in death are increases due to patients prescribed with opiates for chronic pain. So there have been several studies addressing this issue. And there's an important one from Amsterdam and colleagues who use the same indicators for opiate-related harms as in US and compared with data from Germany, France, UK, and Netherlands. And they found no evidence of a current or emerging opiate crisis in these European countries except Scotland. And one of the organizers of this Congress, EMCDDA, also analyzed the data, and they came to the same conclusion that that Europe as a whole isn't facing an opiate crisis of the size and nature in the US. So we did a survey with all of our chapters of the European Pain Federation, including one of Eastern Europe. And we asked the representatives to check their national data if there's been a trend in opiate prescriptions and of drug-related emergency departments and substance use disorders and of deaths in the last 20 years. And the results are very mixed. So Europe is very different. So in most European countries, the prescription of opiates increased to 2016, but with a very large difference from Eastern European countries and North and Western European countries. Opiates are mainly prescribed for acute pain and chronic non-cancer pain in Western and Northern European countries. There was a parallel increase in opiate prescriptions and some proxies of opiate-related harms in France, Finland, and Netherlands, but not in Germany, Spain, and Norway. And finally, there are no robust data available on whether prescribed opiates for pain patients contributed to opiate-related harms. This is very important if you're a clinician, and you have to say it's a politician sometimes. We even have a debate in the German parliament in 2019 if there's an opiate crisis in Germany. So, just to conclude, there are marked differences between European countries in trends of opiate prescribing and of proxies for opiate-related harms. Europe as a whole is not facing opiate crisis. And it's very important that discussions on the potential harms of opiates should not obstruct their prescription for cancer pain and palliative care. This is a really risk in Eastern European countries where the undersupply with opiates for these indications, and some politicians have discussed to cut down the availability of opiates even for cancer pain care. So please allow me some comments on the US crisis from a European point of view. I think this opioid crisis in USA and Canada is not only an opioid crisis, it's a crisis of the US healthcare system and of the US political system. And this is a quotation of a US author. Nobody questions that drug supply was a key factor in the initiation of the US opioid crisis. But the role of opiates, they served as a refuge from physical and psychological trauma, concentrated disadvantage, isolation, and hopelessness. And it was the over-reliance on opiate medications as a quick, simple answer and solution of chronic pain, which you have heard is a very complex disorder and is associated with mental health and social problems. So just to show you what differences we have between North America and Europe as an example for Germany. Canada, Germany, and USA belong to the countries with the highest consumption of prescribed opiates per person. But you see here data that more people in the US are prescribed opiates than in Germany. High dosage prescriptions, let's say above 200 milligram morphine equivalent a day, are much more prevalent in Canada as they are in Germany. The number of opiate addictions, heroin, synthetic opiates, in the general population is 10 times as high in USA than in Germany. And drug deaths are 100 times higher in the US as in Germany. So we really have differences in our countries. And as well with some of our healthcare system. Physical and psychological therapy are covered for everybody by the German healthcare system, as well as treatment for chronic pain and addiction for patients with substance use disorders. And we have different attitudes of patients and physicians towards pharmaceutical pain management. Not everything is big and quick in our healthcare system. And there are also some differences between the guidelines. So we have the first guideline, opioids for cancer, non-cancer pain, has been published in 2009 in Germany. And they were very critical right from the beginning with opioids. We try to destroy the myth of the WHO letter of analgesic treatment that opioids are the most potent painkillers. This is not true for non-cancer pain and even discussable for cancer pain. So non-opiates work sometimes better for non-cancer pain than opioids. And all these topics you have now seen in the US CDC guidelines 2022 with shared decision-making, the preference of non-pharmacological therapy, we have these although in our guidelines in 2015 and in 2021. And I think a very big difference is we do not talk about chronic pain, we talk about chronic non-cancer pain. Just from the beginning, we said that these recommendations are not valid for palliative care and cancer pain, and we're happy that 2022, the US also realized it, that you should make a difference between chronic pain. So my last topic are the clinical practice recommendations of the European Pain Federation, which was a multi-step consensus process and a systematic search of literature, and public comments and reviews also from US experts. So first, and I think here we also agree with NICE and with CDC, that opiates are never the first choice for chronic non-cancer pain. You should always first optimize non-pharmacological treatments and consider non-opiate analgesics. But you have to be honest. The evidence for the efficacy of non-opiate analgesics for most chronic non-cancer pain symptom is as weak as for opioids. So you can consider a trial of opioids if established non-pharmacological treatments and non-opiate analgesics are not effective or not tolerated or contraindicated or not available. And this is a very frequent situation in clinical care. I see a lot of patients with a lot of internal diseases, and some of the more potent non-opiate analgesics like NSAIDs, they can be used because they are contraindicated because of the renal and heart insufficiency of the patients. So we also make a distinction, Cathy, between primary pain and secondary pain. And of course, opioids should not be considered for chronic primary pain, for example, for headache, for IBS, for fibromyalgia. But they can be considered with the preconditions I've mentioned before for some chronic secondary pain symptoms. And I think this is a difference also to the NICE guideline and CDC guidelines. We have a long list of different diseases with mainly nociceptive and neuropathic pain mechanism where you can consider it. So it's much more for the clinician to have distinctive diseases defined. So to prevent potential abuse of prescribed opioids, we recommend to screen for mental disorders before you prescribe opioids. That is not to say that you should not prescribe opiates to a patient with a history of substance use disorder or of depression, but you have to be very careful and survey the patients in close steps. Another thing is to set realistic goals of therapy with the patient. A lot of patients have unrealistic expectations toward any kind of pain treatment. They expect pain relief, complete pain relief, or at least 80%. And I think a lot of clinical work, is to define with the patient realistic goals of therapy. And this must not be a substantial decrease of pain intensity, but an improvement of daily functioning. And I think although there's a concordance with the NICE guidelines, that pain intensity is not the appropriate marker or goal of pain management. So we also have some critical doses which should not be exceeded, but only in exceptional cases. It's about 90 milligram morphine equivalent a day. And very important, you should only continue an opioid therapy in patients who are treatment responders. That is to say, patients who achieve the predefined individual goal of therapy and which tolerate the medication and have no serious side effects. So if you have started a therapy with opioids in patients with chronic non-cancer pain and he's a responder, nevertheless, we recommend that you have a regular review every 1 to 3 months if these individual goals of therapy are met, if there are any adverse events, including opiate disorders of misuse. And we recommend urine drug screening if you suspect misuse or illicit drug use. And with clear stopping rules when you should discontinue opiate treatments if the individual therapeutic goals are no longer met, or if they are achieved in the meanwhile by other therapies, let's say psychological therapies, or if the urine drug tests are positive or refused, or opioids are used in an abusive manner. So when we also, in responders which have no severe side effects, we recommend to discuss after 6 months of therapy a drug holiday, that is to say a reduction of opioid therapy, and to check if there has been a response to non-pharmacological treatments which have been used in parallel. So what is about problematic use of prescribed opioids? Yet it happens with patients with chronic pain. So from our clinical experience in Germany and my very personal experience, it happens very rarely if you have the right appropriate patients which has met the criteria for opioid treatment. And it's very difficult to define what is an opioid use disorder. There's a slow transition of appropriate use, misuse, abuse, and addicted use. And I think this is very important for all this data on opioid use disorder in chronic pain patients. You have to be aware that the DSM-4 and 5 and ICD-10 and 11 criteria have not been designed for patients prescribed with opioids for chronic pain. And the American Psychiatric Association explicitly states that these criteria are not appropriate for individuals taking opioids when patients are under adequate medical supervision. And at least ICD-11 has removed the criteria of tolerance and withdrawal symptom, which are often used as key indicators for substance use disorder and psychiatry for patients which have been prescribed opioids for chronic pain. That is to say, we need additional criteria for an use disorder of prescribed opioids, and our EFIC guidelines get a lot of clinical indications when you can suspect abuse and dependence and addiction of prescribed opioids. So we also give some treatment options for opioid use disorder of prescribed opioid use disorder, and this really depends from the local resources and national legislation. So you can do opioid tapering, and we do it outpatient and inpatient. You can continue the therapy with a stable opioid doses to sustain pain relief, or you can switch to buprenorphine or methadone or polymethadone therapy combined with psychological therapies if they are available. So there's also a command on prevention of non-medical use of prescribed opioids, and we have realized, thanks to data of the USA, that acute pain therapy by opioids after surgical and individual procedures, this is a way into chronic opioid therapy, that these acute pain therapy with opioids should be discontinued as soon as clinically indicated. So there are also some recommendations of the prevention of non-medical use of prescribed opioids by risk screening tools, controlled substance use agreements, and compliance monitoring. So I want to conclude, what have we learned from the from the North American opioid crisis? This North American opioid crisis should not impede the use of opiates for cancer pain and palliative care, not for chronic non-cancer pain in some carefully selected and supervised patients. These patients should be selected and supervised according to the European Clinical Practice Recommendations on opiates for chronic non-cancer pain. And to achieve these goals, a regular continuous medical education is necessary. So what is the way forward? So I refer to the US Stanford Lancet Commission's recommendations. And I think these recommendations have only different domains. And so as a physician, I can only refer to domain 2 on the recognition of risk and benefits of opiates in the drug approval process and promote opiate stewardship in medicine. The other domains, 3, 4, and 5, these are only can be achieved by our political system. That's to say, to create healthy environments or to maximize the benefit and minimize the adverse effects of criminal justice system involvement with people addicted to opiates. Thanks for listening.
Thank you so much, Winfried. I'm going to stay here, but thank you so much for that different perspective. It fitted very well with the other two talks. I think you have a lot in common, and also it was a very clear description of the ways in which we need to learn from each other, but also not assume that guidelines drawn up for one nation and one system will necessarily fit another. And it was a really welcome and interesting point. So thank you, Winfried. Yeah. I'd like to get the three of you talking together now. Cathy and Chris, I think you're going to have to fight over a mic there, or share one. Move it towards you. So everybody here on this table, I'm guilty as well, has been involved in drawing up guidelines. And one of the things I think that you outlined so vividly in your presentation, Chris, is the process of drawing up guidelines, finding out how they get used, and then having to look again. And I think if clinicians are following you, and policymakers are following you, and patients are the ones who are sitting there often thinking, but they're changing their minds. You know, this isn't what they used to think was good for me. Now they're saying that. And I'd just like to hear from all of you about what you think we've learned in this field about drawing up guidelines and guidance, and how we can use it, I don't know, how we think about the whole process in this very, very complex field, just to hear some of your thoughts. I'm looking to see who wants to go first. You go.
Yes, thank you, Sarah. And I think that was a theme between the three of us, the use of guidelines. And obviously I speak mostly from a NICE perspective. I think the first thing to say is that I'm sure all of our guidelines involved patient partners, people with lived experience in the guidelines, and that's been a really important, certainly a nice, really important check and balance into what we produce. I think sometimes there's a willful misuse of guidelines. There was a big backlash against the NICE guidelines from professionals in pain medicine who felt that their integrity was being questioned, that their role in life was being questioned. But the guidelines really very clearly state that these are not rules, that these do not they do not overcome the responsibility as a clinician to assess carefully and decide what's best for that patient. And they don't need to be slavishly followed. And I think certainly the early CDC guidelines, particularly the dose thresholds in the UK, have been very, very slavishly followed outside what they were meant to be, and with things ranging from every patient on over 120 milligrams of morphine a day being sent to an addiction service, and people not understanding that if somebody's on 500 milligrams of morphine and they get to 300 milligrams of morphine, that's a really good piece of harm reduction, even if they don't get down to 120. So I think what I learned from Chris's talk is that it's the implementation. I think the process is good. I think the patient involvement is good. I think the evidence syntheses are good, but it's the kind of messaging around how they're launched. And there will always be interested parties who are keen to discredit guidelines, I'm afraid. And by cherry picking from it, it's always possible to do that.
I would just add, I mean, it was a multi-year process in the US, so concurrent with systematic reviews that were being conducted, we embarked on a process to engage individually with patients, providers, caregivers to understand the challenges that they face, not only from what happened with 2016, but just, you know, in their everyday, what are the challenges? And then we engaged our advisory committee for the Injury Center at CDC, which is an outside group of experts. We put it out for public comment for 60 days. We got about 5,500 comments that helped shape, you know, where the final guideline landed. We cleared it through other agencies in the federal government to get their perspectives. So we tried to be very transparent about the process, learning lessons from 2016. But I want to pick up on Cathy's point that I think we see in many disease states that the existence of guidelines doesn't change behavior. It is that implementation piece. And I think for us, especially because of a focus on addressing equity and disparities in pain care, we recognize that the work for us really starts when we issue the guideline. Continuing to engage with patient groups, continue to engage with provider groups, but also with others in the US system who pay for care, because many of the non-pharmacological treatments that we want people to optimize are not covered. They're not accessible in communities. And the guideline is not going to change that, but it can be a roadmap to say, here's the evidence to support why you should pay for exercise or non-pharmacological treatments. So I think that's sort of the now that we're existing in after we put out the guideline, is to really help advance pain care through engaging with the other partners who have a lever.
Winfried, do you have a comment? Oh, yeah, I think you've got a mic.
Yes, I think this is a very big difference. Though these non-pharmacological therapies, they are covered in Scandinavian countries, in Germany, in France, and so on. Therefore, this is one reason why we haven't this amount of a problem, as you see. And I hope really that your healthcare system and your political system changes. And I want to pick up a second point, is really know that guidelines do not change physicians' behavior, or very rarely. So therefore it's very important to engage patients' organizations, and we did it right from the beginning. And I think we can achieve more we have patient versions of these guidelines. We have also a German National Center of Excellence, which produces information for patients. And we have since 6 years an information on appropriate use of opiates for chronic non-cancer pain. And I think, though my hope is that we can change more easily the patient's attitudes and behaviors than the one of the physicians.
And I think one of the things all of you have put across is that this is a complex problem in which everybody has to take their time, and assessments and decisions should be taken slowly and carefully while listening to feedback, which all of you have said. And I think I'm interested in whether you feel that there's pressure to solve problems quickly in this field, or to have more straightforward answers. Have you felt that there is that sort of pressure to treat this field as if it's less complex than it is?
Yes. I mean, I think that's, you know, especially in the context of over 100,000 overdose deaths, there's tremendous political pressure to lower that number as quickly as possible. But I want to underscore the point that I think we all made at some point in our talk, is that this is complex. Whether you're looking at it from the pain side or the substance use and overdose side, there are many parallels with social determinants of health, adverse childhood experiences or childhood trauma, you know, incredibly common among people who use substances, whether they have pain or not. And, you know, addressing those things have to be part of the solution, but they're not easy. They're not easy solutions, and it really takes multiple components of the political system, the health system, criminal justice, community-based organizations to do it. And I think that's just not what often people want. They just want, what's the single thing that we can do that's going to address this? And I think we have demonstrated quite effectively in the US that there's not a single thing that we can do. I think for many years, people are like, well, if we just reduce opioid prescribing, then we'll solve the problem. And clearly that has not played out.
Lee?
I would agree. Good care costs time. And certainly in the UK, time is something we don't have. There was a thing in the papers yesterday about one general practitioner who'd seen 200 patients in one day with difficult conditions. How can you begin to unpack in a sensitive way people's early childhood experiences and so on? I think the message that we're trying to promote is that there are many people in the community around that patient, and from sort of a bottom-up community-built support for patients with pain, we can make sure that there is time. It doesn't have to be the general practitioner, it doesn't have to be the doctor, but particularly the new social prescribing roles who are well versed in the social determinants of ill health and well versed in issues around childhood trauma. Those are the people that can take time and build relationships with patients. But time is the resource that nobody has, and time is what solves this problem.
Winfried, do you want to have a comment for us? Or?
So we never experienced through any guideline the political pressure in Germany.
Congratulations.
Thanks.
I guess one of the things I'm interested in from having kind of worked a little bit with Cathy, actually, in a local setting. I'm an addiction specialist, Cathy's a pain specialist, is to think that all of us in our special fields are used to having certain kinds of difficult conversations with patients, and in addictions fields we have certain difficult kinds, which are sometimes around prescribing, they're sometimes around other things, and I think that the kind of process that Cathy's been describing, where you're actually, a person is saying that a medication is not helping them, and the solution is probably the dose is not big enough, and then the difficult conversation is to say actually probably it's not helping you at all, and that's a frightening kind of thing to face. And I'm just wondering if certainly for the clinicians here you've got some things to say about those difficult conversations, and how we learn as a field, as different fields, to perhaps take on the skills to have those difficult conversations when we need to. Cathy, I don't know if you want to start with that one, because this is one that I know you do.
I think, unfortunately, difficult conversations and core competences in mental health aren't in the syllabus for pain medicine professionals in the UK. I think the difficult conversations are the core. Managing difficult conversations is the core of this. What we found very successful is we've trained our GPs, pharmacists, and anybody who wants to, free of charge, in health coaching training, which obviously allows that much more personalised, listening, empathic type of approach. So the person drives the agenda, and health coaching training has been tremendously empowering for our clinicians. They find that they have joy in working, that they no longer dread seeing a patient on their list. They feel that conversations are much less confrontational. They feel they're working alongside the patient, and they feel that their role is a fixer rather than a facilitator. And I think those coaching type skills, motivational interviewing to a degree, are really important and should be much more central to the curriculum of anybody dealing with long-term conditions.
Yeah, we certainly, as part of the guideline, release a set of toolkits, ancillary materials, training for providers, as well as patient-centered communications. And part of that is around motivational interviewing and how to have those conversations. I know other agencies, like Substance Abuse and Mental Health Services Administration and others, also have that on the addiction side, to have, how to help facilitate clinicians in becoming more comfortable. I mean, I'm trained as a clinical pharmacist, and I'm very good at identifying the patient who's got the problem. I wasn't trained in then the so what. How do I have that conversation with them to motivate behavior change or discuss difficult topics? And I think that's pretty common for many clinicians.
So, German pain physicians have to undergo special training in psychosomatic basic care, and we get some small extra honoraria to take part in regular interdisciplinary pain conferences to discuss difficult patients. And second, we have a lot of multidisciplinary pain teams, and in the outpatient department of work, we have a psychiatrist who is an addiction specialist.
Okay. I'm kind of looking at the time. and thinking this has been a really, really fascinating session, and it's a shame to stop. I actually love hearing you talk to each other, so it's a pity that we don't have more time for that. Also, I'm really sorry we haven't taken questions from the floor. You can see that it's difficult, but I think we're going to go and have some coffee now. And so if people do want to try and catch Cathy or Chris or Winfried afterwards, they can choose whether to kind of run away and get some coffee or to try and answer some questions. But thank you so much to all our speakers.
That's the thing with that. Yeah, yeah, I know. Yep. Yeah, yeah.
He's very sweet. He's a lovely man.
Yeah.
I know. Yeah, no, sorry.
What's her name? Who was when we were talking
Stage a minute ago.
about changing the California Health Interview Survey. It was
Oh.
Darren.
Yeah.
And Darren is kind of involved on Howard's, but I guess not on yours.
He was, and then as soon as the money, I have no idea. I mean, I don't know him that well. I mean, as soon as it came in, he's like, I've got other stuff to do, or I'm too busy. I was like, so brought in some other people. So, so yeah, so we're working on that again. But the thing is UCLA is so cheap relative to Rand, right?
Oh, yeah.
So so we're trying to get the money from the state, and we need to make sure that the UCLA amount is higher than the Rand. Yeah. Oh yeah. Yeah. Oh, none is probably. That's like the only time that's ever happened. Simon's way down there.
You have to look this way, Caitlin, too. Come on in, Simon.
Yeah. Oh, yeah.
Oh, yes, I know, doesn't it? Thank you.
Okay.
Who's going to run social media while you're president?
Yeah.
Yes.
I know. About time.
Lorena?
Has anybody seen Chris this morning?
Where's the, I thought that, but then I didn't do anything. Yeah.
Hi, everyone. We're just waiting for two of our panelists. Is your mic? There we go. Is this on? Now it is. Good morning, everyone. We are waiting on two of our panelists who I'm sure are trying to get through that coffee line. And we'll be here momentarily. I haven't seen Lorena. Have you seen Chris?
There's Chris.
Yes, Chris.
Yeah.
Hard to navigate that line. Good morning. Yeah.
I've lost my phone. My phone stopped ringing.
Oh, no.
Yeah.
Hi there.
Sucks.
Morning,
So
Chris.
I can't even look at the program.
Oh, no.
Consent form?
Digital gap.
Sure.
Yes.
Yeah.
Big time.
Yeah, sure.
Oh, Chris. Okay.
You made it.
Good morning.
Good morning.
A consent form for because the main stage is always.
There's just one more panelist that we are waiting for. We'll give her a minute or two here, and then we will probably get started and have her jump in when we arrive. Oh, thank you. Good morning.